Bone marrow failure. So we're going to look at the pathophysiology of bone marrow failure. So the definition for pancytopenia, at least, is it means that it is decreased circulating red blood cell, white blood cells, and platelets, really the whole line of cells. Mechanisms involved is your destruction of hematopoietic stem cells, premature senescent and apoptosis of stem cells, ineffective hematopoiesis, disruption of bone marrow microenvironment, decreased production of growth factors and hormones, and infiltration of marrow spaces by abnormal cells. For aplastic anemia, there are some characteristic features. First one would be pancytopenia, again, that decrease in red blood cell, white blood cell, and platelet count. They can have a reticulocytopenia, which is that low reticulocyte count, which basically indicates a reduced red blood cell production. Bone marrow hypocellularity, so they have a marked reduction in cellularity within their bone marrow, and depletion of the hematopoietic stem cells. Luckily, this is a rare disease where 80 to 85% are actually acquired and 15 to 20% are inherited or they are congenital. For the etiologic classification, we have idiopathic, which basically just means there's no known cause, and that accounts for 70% of the cases. And then we have secondary, which accounts for 10 to 15% of the cases, and this is due to exposure to certain drugs like chemotherapy and certain antibiotics. Could be because they're exposed to certain chemicals like benzene or even certain pesticides, or it could be from certain infections, even like viral hepatitis or parvovirus B19. For the incidence in North America, approximately 1 in 500,000 people will be diagnosed with aplastic anemia. There is a higher incidence in Asia and East Asia, which is about 2 to 3 times more frequent than here in the United States. It can occur at any age, but there are 2 peak age groups, and that is 15 to 25 years and people who are over 60 years old. Etiology for this is mentioned earlier. We have the drugs, so chemotherapy agents, antibiotics, and others, chemicals like benzenes and pesticides, idiosyncratic reactions, so there could be unpredictable immune-mediated responses to certain medications or chemicals, radiation, so therapeutic or accidental exposure, infectious agents, so viral infections like hepatitis, parvovirus B19, and even the Epstein-Barr virus, and pregnancy. So in rare cases, it can be related to the immune or hormonal changes that occur during pregnancy. Acquired aplastic anemia is a condition that is characterized by bone marrow failure and pancytopenia. So despite normal bone marrow stromal cells and elevated growth factors, there is a severe depletion of the hematopoietic stem cells and progenitor cells. Some pathophysiological features for this would be bone marrow environment. So those stromal cells, which are the supportive cells of the bone marrow, are functionally normal, but the hematopoietic growth factors are actually elevated, and this can indicate a compensatory response to the cytopenias. So despite this, hematopoiesis fails due to the intrinsic stem cell damage. You can also have stem and progenitor cell depletion. So there is a marked loss of hematopoietic stem and progenitor cells, which are essential for blood cell production. This can lead to a decrease in red blood cells, which can lead to anemia. It can also lead to a decrease in white blood cells, which can lead to an increase in infection risk, and can lead to a decreased platelet count, which can lead to bleeding tendencies. So the mechanism of cell damage, so the first one is a direct damage. So it can be toxic insults, which can directly damage these stem cells. So cytotoxic drugs, chemicals, ionizing radiation, and certain viruses can all do that. The other one is immune-mediated damage. So their apparent immune responses may target and destroy those stem cells, which once again are triggered by drugs, viruses, or chemicals. The T-cell mediated cytotoxicity is a major mechanism, and it is supported by response to immunosuppressive therapy. Another thing is the telomere shortening. So peripheral blood granulocytes often have shortened telomeres in aplastic anemia. The telomeres are a repetitive DNA sequence at the chromosome ends, and these help protect chromosomes from degradation. So if we have shortened telomeres, it can result in loss of chromosomal stability, proliferation arrest of stem cells, and premature apoptosis of those hematopoietic cells. Some general symptoms for patients with aplastic anemia is they can reflect the pancytopenia, so especially anemia. You have your common symptoms like pallor, fatigue, and weakness, and these are due to a decreased oxygen carrying capacity from reduced red blood cell production. You can also have prolonged anemia. That would lead to cardiovascular complications. So if anemia is prolonged or severe, it could result in tachycardia, which is the compensatory increase in heart rate, hypotension due to reduced blood viscosity and volume, cardiac failure, which is a high output heart failure from chronic anemia, or even death. So in cases of untreated or unresponsive disease could occur. Thrombocytopenia symptoms, so that means it's a low platelet count, which can lead to bleeding tendencies. So they'll have common bleeding manifestations, which could include petechiae, which are those pinpoint skin hemorrhages. They will bruise easily. They can have epistaxis or nosebleeds, mucosal bleeding, like in oral or GI mucosal, menorrhagia, so heavy menstrual bleeding, retinal hemorrhages that could affect their vision. They could have intestinal bleeding, which can cause malignant or hematochezia. Intracranial hemorrhage as well could happen, and this is life-threatening, especially with severe thrombocytopenia. For laboratory findings, we'll have a complete blood count or CBC and reticulocyte performed. So some key findings or some findings in this would be a pancytopenia. This is decreased counts of all those 3 blood cell lines. So we'll have neutrophils will be decreased. Lymphocytes will actually be normal potentially or even decreased. Hemoglobin will be low, usually less than 10. The MCV will be normal or mildly increased, so that will show that the cells are normocytic or macrocytic. The reticulocyte count, so the percent reticulocyte and absolute count will both be decreased, and this will reflect reduced bone marrow activity. Peripheral blood smear examination will confirm pancytopenia. Typically, there's no dysplasia, which will help rule out myelodysplastic syndromes, but it may show normocytic or macrocytic red blood cells, a decreased reticulocyte, and low or absent immature cells. We could also run iron study testing, so serum iron will often be normal or elevated. Transferrin saturation may be increased, and this is due to a decreased utilization of iron or ineffective erythropoiesis. Iron overload can occur if patient starts to receive multiple transfusions to try to correct their anemia. We can also run a liver function test, and this is performed to rule out hepatitis-associated aplastic anemia, and we can evaluate for liver involvement in differential diagnosis. This may show mild abnormalities if viral hepatitis is present. Then we have paroxysmal nocturnal hemoglobinuria, or PNH testing. So PNH clone testing can be done via the flow cytometry. And this is important because some cases of aplastic anemia are actually associated with PNH clones. So PNH may emerge later or actually even coexist, so they may overlap these syndromes. Bone marrow examination. In the bone marrow aspirate and biopsy, you're going to see hypocellular marrow. Cellularity is going to be less than 25%. You're also going to see fatty replacement of the marrow space. There's really going to be no abnormal infiltrate, fibrosis, or dysplasia with this aplastic anemia, and it's essential for diagnosis for the bone marrow at least. It helps differentiate from myelodysplastic syndromes, leukemia, and any infiltrative diseases. All right, treatment and prognosis for aplastic anemia. So treatment, first step would be to remove the causative agent, so discontinue exposure to the suspected drug, chemical, or toxin. This is important for halting further stem cell damage, and it may lead to spontaneous recovery in some mild cases. Some patients may need a blood product transfusion. This would be used to manage anemia and thrombocytopenia, but it's not given to just everybody all the time because it can have some issues such as alloimmunization and iron overload. So if they do a transfusion, they would prefer to do a leukocyte depleted and irradiated blood product and a single donor platelet to reduce alloimmunization risk. They can also do a bone marrow transplantation, and this is actually the treatment of choice in eligible patients. So to be eligible, they have to be less than or equal to 40 years old, and they have to have the availability of an HLA identical sibling donor. This will actually offer a curative potential, and they have better outcomes in younger patients due to their lower transplant-related complications and better immune recovery. For immunosuppressive therapy, this is indicated for patients that are over 40 years old or with patients without an HLA identical sibling. So standard immunosuppressive therapy regimen will include an anti-thymocyte globulin or cyclosporine. How they work is they suppress the autoimmune destruction of the hematopoietic stem cells. The response rate is usually about 60 to 70% will have an initial response, and some will actually relapse depending on the patient. Supportive therapies that can prevent and manage infections due to neutropenia, so they can be put on an antibiotic or antifungal prophylaxis. And it's important to have early and aggressive treatment of febrile episodes. For prognosis, so children will have a higher survival rate than adults. About 80%, 6% will have a 10-year survival rate, where adults will be about 56% survival rate. Well, 10-year survival rate. Prognosis is going to depend on age, the response to the therapy, the presence of the PNH clone or cytogenetic abnormalities, and access to supportive care. All right, so we go on to inherited aplastic anemia. So the first one is Fanconi anemia. So by definition, Fanconi anemia is a chromosome instability disorder. It is characterized by aplastic anemia, congenital physical abnormalities, and increased susceptibility to cancer, especially acute myeloid leukemia and squamous cell carcinoma. It is the most common inherited bone marrow failure syndrome. So the incidence, it is estimated that we have about 1 to 5 cases per million people. And there's actually a carrier frequency. So 1 in 300 in the general population in US and Europe are actually a carrier. It's approximately 3-fold higher in the Ashkenazi Jewish population and the South African populations. Autosomal recessive inheritance is most common, but some rare X-linked forms do exist. So clinical findings. We will see progressive pancytopenia. This will often present in childhood. They will have a risk of developing myelodysplastic syndrome or AML. Some physical abnormalities they're variable, but they are kind of common. They may have a short stature, abnormal thumbs or radii, skin pigmentation abnormalities, microcephaly, renal abnormalities, developmental delay, or learning difficulties. They also have a cancer predisposition, so they have an increased risk of leukemia, like we mentioned earlier, especially AML or acute myelogenous leukemia, head and neck squamous cell carcinomas, and gynecological and gastrointestinal cancers. So genetics and pathophysiology, this is caused by a biallelic mutation or deletion in one of at least 21 genes involved in the Fanconi anemia DNA repair pathway. These genes include the FANCA, FANCC, and the FANCG. These are involved in the DNA interstrand cross-link repair. So defective DNA repair will lead to chromosomal breakage, apoptosis, and bone marrow failure. For diagnosis, the chromosome breakage test using the diepoxybutane or mitomycin C will help with diagnosis. Some laboratory findings for this, they will have a pancytopenia. This again presents fairly early. They'll have a low hemoglobin, a low white blood cell count, and low platelets. They'll have microcytosis, so they'll have an increase MCV, which will often precede the full marrow failure. We may see an increase in the fetal hemoglobin level. That reflects that bone marrow is stressed and ineffective erythropoiesis is happening. We can do an AFP or an alpha fetoprotein. So we will usually see an elevated AFP level or sometimes seen. It's not specific, but it is supportive in diagnosis, especially in younger patients. We can do a chromosome breakage study. This is the diagnostic gold standard for Fanconi anemia. Tests use clastiogenic agents like the diepoxybutane or the mitomycin C. Positive result shows increased chromosome breakage and rearrangements, and it confirms a chromosomal instability, which is typical of Fanconi anemia. For treatment, we're going to do supportive care, so blood transfusions for anemia or thrombocytopenia. We can do cytokine therapy, which may provide temporary benefit, but it's a limited long-time efficacy. Infection prophylaxis and treatment will occur as well. You can do a curative option, which would be the hematopoietic stem cell transplant, and this is the only curative therapy for marrow failure. Some complications from this, though, could be a higher risk of graft versus host disease and an increased toxicity due to DNA repair defects, which requires reduced intensity conditioning. All right, and then we move on to pure red cell aplasia. So by definition, pure red cell aplasia is a rare hematologic disorder which is characterized by a selective and severe reduction in erythroid precursors within the bone marrow, while other cell lineages like myeloid and megakaryocytic remain normal. This leads to anemia without accompanying leukopenia or thrombocytopenia. So we have different types of pure red cell aplasia. So the first one is acquired. This form occurs later in life and can be classified into primary and secondary types. So primary acquired pure red cell aplasia is often idiopathic or associated with autoimmune conditions. In these cases, the immune system may target red cell precursors, which inhibits erythropoiesis. In secondary acquired pure red cell aplasia, this occurs in association with other underlying conditions, such as a thymoma, which is the most classically associated neoplasm, during hematologic malignancies, including chronic lymphocytic leukemia, solid tumors, viral infections, especially that parvovirus B19, chronic hemolytic anemias, collagen vascular diseases like systemic lupus, drugs and chemicals, and that could also, suppress the erythropoiesis. Transient erythroblastopenia of childhood. This is a self-limited form of pure red cell aplasia that typically affects young children. A viral infection is found in approximately half of the cases, and it is believed that such infections trigger an immune-mediated suppression of erythroid precursors. So despite its acute presentation, this usually resolves spontaneously within weeks to months. For laboratory findings, we would see normocytic anemia, indicating that red blood cell size is preserved despite the low count. Reticulocytopenia, showing inadequate red blood cell production. We will see hemoglobin F levels, which are normally in the normal range. Erythrocyte adenosine deaminase, or ADA levels, are usually normal, and it helps to distinguish the pure red cell aplasia from other congenital anemias like diamond blackfan anemia. Bone marrow examination is actually essential, and it will show a marked reduction or absence even of erythroid precursors, while granulopoiesis and megakaryopoiesis will remain normal. For treatment, it would be for symptomatic patients is to do a red blood cell transfusion to help manage that anemia. Further management will depend on what's actually causing it. So we could do immunosuppressive therapy, which may be used in autoimmune or idiopathic cases. Could do a surgical removal of a thymoma, which can lead to a remission in thymoma-associated pure red cell aplasia. Could also do antiviral therapy, which may be indicated for parvovirus B19 infection. And also withdrawal of offending drugs. So if it's using drugs that's causing it, stop doing it. That diamond blackfan anemia, it is a congenital pure red cell aplasia. So by definition, diamond blackfan anemia is a congenital erythroid hypoplastic disorder that presents in early infancy. It is characterized by severe anemia due to a deficiency in red blood cell precursors, while white blood cells and platelets typically remain unaffected. The incidence for diamond blackfan anemia is luckily it's a rare disorder. It occurs in about 7 to 10 cases per million live births. It is one of the most well-characterized inherited bone marrow failure syndromes. So the genetics of this, so diamond blackfan anemia, is caused by mutations in at least 17 genes, many of which will encode the ribosomal proteins involved in ribosome biogenesis and function. These mutations will disrupt erythropoiesis, which will lead to a selective failure of red cell production. The most commonly affected gene is the RPS19, although there are others like the RPL5 and RPL11 can also be implicated. For clinical findings, the diamond blackfan anemia will often present with congenital physical anomalies, which occur in nearly 50% of patients. So these common features will include craniofacial dysmorphisms like a flat nasal bridge, wide eye set, short stature. They may have some thumb anomalies as well, like hypoplastic thumbs. They may have some neck malformations, so a web neck or even a short neck. Patients will typically present within the first year of life with signs of severe anemia, such as pallor and poor feeding. For laboratory findings, we're going to see severe macrocytic anemia, which is often, once again, presented during early infancy. We'll see reticulocytopenia, which will indicate decreased red cell production. Normal white blood cell and platelet counts, which will help distinguish it from pancytopenic conditions. We'll also see elevated erythrocyte adenosine deaminase and increased fetal hemoglobin, which could be supportive findings, though they're not super specific. The bone marrow examination will reveal a marked reduction or absence of erythroid precursors, while other lineages will appear normal. For therapy, they could do a red blood cell transfusion to manage anemia. They could use corticosteroids, which will stimulate red cell production in many patients, though long-term use has significant side effects, so we don't want to do it for too long. In the refractory or transfusion-dependent cases, they can do hematopoietic stem cell transplantation. It's really the only curative therapy, especially effective in younger patients. The prognosis of Diamond-Blackfan anemia has actually improved with the advances in supportive care and transplantation. So 75% survival at 40 years of age and actually up to 90% survival in children under 10 years who undergo the successful bone marrow transplantation. They will require lifetime or lifelong monitoring due to the risk of iron overload, endocrine dysfunction, and a slightly increased risk of malignancy. Myelospastic anemia, the definition of this is it is a type of bone marrow failure which is caused by the infiltration of abnormal cells into the bone marrow, which leads to the destruction and displacement of normal hematopoietic tissue. The infiltration process results in impaired blood cell production and the release of immature cells into the peripheral blood. Common causes of bone marrow infiltration can include metastatic cancers, so like breast and prostate, lung, hematologic malignancies such as lymphoma and leukemia, granulomatous disease, so tuberculosis is an example, myelofibrosis as well. For laboratory findings, you'll see anemia. It's typically mild to moderate in severity. Red blood cells are normocytic, although anisopolycytosis, so variation in size and shape, may be present. Reticulocyte count is low, which reflects a suppressed erythropoiesis. You'll also see teardrop or dacrocytes on the red blood cells. They are often seen, which can indicate a marrow distortion. Nucleated red blood cells will appear in the peripheral blood, which is also a sign of marrow stress or infiltration. Immature myeloid cells, such as myelocytes or promyelocytes, are released into circulation, which can create a leukoerythroblastic blood picture. Megakaryocyte fragments may also be observed, which can further support the marrow infiltration. For clinical relevance, the myelocytic anemia is a secondary process, and its identification should prompt investigation for an underlying malignancy or infiltrative disease. Bone marrow biopsy is going to be essential for diagnosis and will typically show fibrosis, malignant cells, or granulomatous infiltration, and that's going to depend on what's actually causing it. Anemia of chronic kidney disease. So anemia is a common complication seen in patients with chronic kidney disease. It contributes significantly to morbidity and worsens quality of life. For the etiology, it could be from inadequate renal production of erythropoietin. The diseased kidneys produce insufficient erythropoietin, which is the hormone essential for red blood cell production. Uremia, so the accumulation of uremic toxins in chronic kidney disease, which can inhibit erythropoiesis and can increase red blood cell fragility, which will shorten that red blood cell lifespan. Hemodialysis and frequent blood draws, so this can lead to chronic blood loss, which can worsen the anemia. Chronic inflammation, so the inflammatory cytokines can stimulate the liver to produce hepcidin. Hepcidin reduces the iron availability by inhibiting intestinal iron absorption and trapping iron in macrophages, leading to functional iron deficiency. For laboratory findings in hematology tests, it's going to typically show normocytic normochromic anemia, and the reticulocyte count is usually low or inappropriately normal given the degree of anemia. So iron studies will also be done, and this is important to evaluate iron status before initiating any therapy. Iron studies are recommended when transferrin saturation is less than 30% and serum ferritin is less than 500. These cutoffs actually help identify patients who might benefit from iron supplementation. Some little clinical notes we have. So treatment involves erythropoiesis stimulating agents and iron supplementation. It's tailored to the iron status of the patient. And managing anemia can improve symptoms such as fatigue and can reduce cardiovascular risk.